Purva. So Ashish, I think it's already 5 minutes past 6, so you can start and request Dr. Ganguly to initiate the meeting.
Recording in progress.
Ashish, are you there? Hello, Ashish.
Sir is there, but there is some issue with Sir Mike.
Okay, Dr. Ganguly, can you start the proceedings?
Yeah. Now just starting the program. Yeah. Good evening and warm welcome to all of you. This is our president-elect, Dr. Devashish, the secretary, and my convener Ashish, and all those who have presented the cases here, and all other members, those who have joined and who are now joining and will join within a short time for our periodic headache subsections academic case presentations webinar. And I think this will be an exciting, interesting, and encouraging academic feast for all of us. Now, if Ashish have joined, Ashish.
Yes, sir, I've joined, sir. Am I audible?
Okay.
There was
You are
problem
audible. So, Ashish, my dynamic convener of this subsection, so now I just hand over to you for the further proceedings. Okay.
Thank you, sir. And so, welcome to the headache subsection webinar. This time we have 3 speakers and some interesting cases. And Dr. Devashish Chaudhary, President-elect of IAN, he will be the moderator. So I would request sir to please call upon the first speaker, Dr. Jasodhara.
Dr. Jashodhara, welcome. Dr. Jashodhara is currently the Assistant Professor of Neuromedicine, NRS Medical College and Hospital, and Institute of Child Health and Visiting Faculty member. She is from pediatrics background and then did DM Neurology and followed by Movement Disorder Fellowship. She has got authorship of about 30 publications in national and international journals. And she is now working on SMA and Wilson's disease. It was a pleasure meeting her during my last visit to Calcutta when I went there to take exam. So Yashodhara, all yours. So you please start with the first case.
Thank you, sir. Thank you, my teachers, my senior colleagues and sirs, and thank you, IAN, for giving me this opportunity. Without much ado, I'll just begin with this case presentation. So I think my slide is visible, sir.
Yes, ma'am.
Yes.
Okay.
You put it in the, yeah.
Okay, so I will discuss a case and ask all of your opinion regarding that. A case of secondary headache with multiple cranial nerve palsy. So this was a 35-year-old male who was laborer by occupation. He was uneducated, right-handed. He was a resident of Midnapur, West Bengal. He is also non-diabetic, non-hypertensive. He is euthyroid. He is occasional smoker and non-alcohol. His chief complaint was obviously headache for 2 months and a history of double vision for the last 1 month and a facial deviation for last 20 days. While he was admitted with us, he had 1 episode of focal seizure with impaired awareness, and going by the semiology of the seizure, it could be localized more or less as an extratemporal seizure, complex partial seizure. So we will be elaborating the headache part, but the double vision, it was on horizontal vision, more on distant vision, and it diminished on closing one eye. And it was there since 1 month and it was progressing. There was a facial deviation which started 20 days back and is in a stable condition when the patient was admitted. He had a similar episode of moderate intensity headache with a facial deviation in 2015. So what happened in 2015 was a moderate intensity headache lasting for about 1 month. He was not very sure about the history at that time, with a history which suggested that he had at that time unilateral 7 nerve palsy, elementi on left side. So this time also in 2023, when he is admitted at NRS, he had a moderate intensity headache and a bilateral 6 nerve palsy. So what happened is, since the past 2 months, he has moderate intensity headache that is persisting throughout the day, throbbing in nature, and started as a left hemicranial, then became holocranial, was occasionally associated with nausea, but not on a daily basis. There was no vomiting, however, no photophobia, phonophobia, exacerbation with postural change, and it got relief to some extent on taking analgesics from different doctors whom he visited before coming to and getting admitted in our hospital. This kind of similar history he had 8 years back, and that also lasted for around 1 to 2 months and eventually got relief by taking different kind of medications. Since the last few years, he had intermittent pulsatile headaches. That was mostly unilateral. That was associated with photophobia, phonophobia, nausea. There was no symptom suggestive of aura. That was relieved to some extent on sleeping and taking medicines. So on asking him into details, he did not have any formal headache type. But we asked him his symptoms and details, and we tried to construct a headache diet. So, in the past 4 months, before the recent change in character, that is duration of last 2 months, 4 months before that, after asking him history and details, there were more or less 15 ictal days of severe headache. The headache at that time, during those days when we asked, was most commonly pressing, mild to moderate in severity, according to him. It was more or less unchanged by physical activity, and it was associated with photophobia. The IDSC classification was utilized to determine that 8 episodes, more or less. We don't have the exact headache diary, but approximately around 8 episodes met the criteria for a probable migraine without aura, while 7 episodes met the criteria for frequent episodic tension type headache. So this was something we constructed approximately without having the exact data for 4 months before the recent change in character. So this patient was having some kind of headache, which was for the few years. This was for the 4 months last, which we documented, and that got a changed character in the past 2 months. So the recent, if we discuss the present situation, the recent change in headache character, we can classify that as a secondary headache with multiple cranial nerve palsy, with which the patient was admitted. So why are we calling this a secondary headache? Because there has been a recent definite change in character, and according to the patient, the intensity was more or less 2 times more the intensity he was having previously. Also, because of the other things which happened, there were multiple cranial nerve palsies associated with that. We thought that this time we can classify that as a secondary headache for this patient who has a background of primary headache, and that can be both, that was mostly migraine without aura and few episodes of episodic tension type headaches. So now examination of this patient in a nutshell. On general examination, we did not find any significant findings. On neurological examination, the visual acuity both eyes were 6/60 and after pinhole 6/24. Fundus, there was blood discharge in both eyes. And cranial nerve examination, there was bilateral 6-nerve palsy and element left-sided 7th cranial nerve palsy. So this was the patient when he was admitted. So there was restriction in bilateral lateral rectus movement, and we can well appreciate the left-sided element type of 7th of palsy here. So with that, with the mind of secondary headache with multiple cranial nerve palsies, we did the investigations. we were thinking on the lines of some inflammatory infective causes. We did all the investigations and ESR was 10, hemoglobin, these things were normal. The total count was more or less normal. The autoimmune panel was more or less normal. Then the vasculitic panel, serum IgG4 was done, which was negative because the patient had recurrent episodes. We did a CSF study. The opening pressure was normal. The protein was high. It was 109. Cell count was 10, a bit on the higher side. We did also TB workup, whatever was possible, which was negative. So with that, we have a secondary headache with multiple cranial nerve palsy. The multiple cranial nerve palsy extraaxial. Probable localization we did was meninges or subarachnoid space. And the probable pathology we thought in this patient was infective or inflammatory. But odd point against infection was a recurrent manifestation. Why will this patient have a similar presentation 8 years apart? And inflammatory, whatever we tried to send the investigations came out to be normal. However, it might be still any kind of inflammatory disease. That was our probable pathology behind this patient. Now we did an MRI. Then what did we see? We saw a left-sided posterior parietal area, a gliotic changes were seen. And in the T1 contrast, we saw this kind of enhancement. We asked our neuroradiologist. One was of the opinion that this was a normal variant, and another was on the opinion that this was a sinus which was enhancing. So there might be a possibility of some kind of inflammation going on. Then the MR angio. The MR angio showed that there was narrowing of left ICA, then the MCA, the entire MCA, the ACA, and the PCA. The entire left-sided, the vasculature was almost obliterated. The ICA is totally atretic. And here, if we see that the skull base, the ECA vessels are trying to do some collaterals. So we were of the doubt whether this is a congenital variant, where the entire left side has gone up, or it is a variant of a Moyamoya syndrome, where we can see the ECA collaterals. But the thing is that the entire ICA is almost atretic. In Moyamoya, we know that there is a particular point of the ICA from where it gets atretic, the supraclinoid part. But here, if you see, the entire ICA has become narrow. So then that was a point of debate. But here we can see the ECA collaterals coming that goes in favor of Moyamoya syndrome. So it may not be Moyamoya disease, but it very well may be Moyamoya syndrome. So in this case, source image, we see that the left ICA is hypoplastic in the left vitreous canal. So this was the DSA was done. The DSA was done by NRS. We don't have a interventional neurology department, but it was done by cardiology department. Here, the DSA, the posterior circulation was not picked up well. So the anterior part, we see only the ICA, and the rest all are ECA collaterals. And this was a puff of smoke appearance. So we would have been very sure that we are dealing with a Moyamoya syndrome if this thing was superimposed on a skull base and we could see the small perforated ECA collaterals. But here it was not done. So, but this gives an idea that puff of smoke, the collateral thing, that the IC is atretic and this the ECA collaterals. So this is a case of Moyamoya syndrome. So the imaging findings in a nutshell, that there is an area of gliosis in the left parieto-occipital lobe, and that was maybe the point from where the seizure originated, as we see that the patient had one episode of extratemporal seizure, focal seizure with impaired awareness, and so that may be the structural epilepsy. And then the MR angio, there was a left-sided supraclinoid ICA narrowing. The entire ICA, in fact, is atretic with thin caliber left MCA, and the left PCA is also attenuated. In the neck, we saw that the left CCA was thin caliber and the arch of aorta was normal. And this was a Moyamoya syndrome can be possible. So actually the Moyamoya syndrome, as the classical teaching goes, that it is a bilateral disease. There is a vascular occlusion, especially from the supraclinoid ICA, that is mostly bilateral. But up to 18% cases, it can be unilateral. And it can be Moyamoya disease or Moyamoya syndrome. And we are thinking more in favor of Moyamoya syndrome. Why? Because we think that there may be some underlying cause that may be the causative for this. So in this patient, what can it be? It can be a post-infectious vasculopathy. So what is the odd that this patient in 8 years' time is having this kind of presentation. And in between, this patient is having a headache, which is suggestive of a primary headache. Many episodes of migraine-like headaches and many episodes of TTH headaches. So is this a post-infectious vasculopathy at all? Then how can it be? So we did not think that this can be a post-infectious vasculopathy. Again, atherosclerosis, very unlikely in a patient who is not predisposed. We do not have predisposing factors. And this patient is 39. It started 8 years back when he was really young. So it is unlikely to be atherosclerosis. Then a fibromuscular dysplasia. And again, we say that we have also done a basal wall imaging. We did not show any signs of inflammation. And the neuroradiologist said that when it was not suggestive of any ongoing vasculitis that is going on. So this we cannot determine unless we do a biopsy. So some important causes that we tried to rule out, there was no history of radiation therapy, no trauma, no brain tumor, meningitis, recurrent meningitis, again, CSF protein was high, cells was on a higher side, but we did not find any particular infection. And this did not, a diagnosis of meningitis does not explain his headache lasting for a few years, the primary headaches which has been lasting for a few years. Then few hematological conditions, this has been all ruled out. We did the tests, HPLC, and it was all normal. Then the autoimmune diseases, these also have been all ruled out. Sarcoidosis, SLE, PAN, these have been ruled out. There has been fibromuscular dysplasia and these things, tuberous sclerosis. Tuberous sclerosis, there was no markers, nothing, and biopsy could not be done. Now, there are particular few mutations which are associated with Moyamoya disease, which we could not do. However, this did not match with any common mutations which presents with such kind of recurrent headaches, multiple cranial nerve palsies. So this is not very usual manifestation. Now, headache and Moyamoya disease are very interestingly correlated. There is a total entity that is called HAMD, that is headache associated with Moyamoya disease. And it is reported in 20 to 76.4% of patients with Moyamoya disease. But however, there is a dearth of literature explaining the nature of headache. And it can also be a presenting syndrome in symptom in Moyamoya disease. In our patient, headache was the presenting symptom. But we did not take it as a important issue unless there was multiple cranial nerve palsy, which triggered a lot of investigations, which after that we found that the patient is having Moyamoya syndrome. Migraine-like headache is initial symptom in as many as 20% of the patients. So there has been a definite diagnostic criteria for HAMD or HAMA. So this was like neuroimaging evidence of Moyamoya angiopathy. And the headache has developed in close temporal relation to other symptoms, signs, and imaging evidence of MMA. And headache has significantly worsened in parallel with the other symptoms. Headache has significantly improved after revascularization surgery. And the headache is not better accounted by any other ICH-T3 diagnosis. And so what causes this kind of headache in Moyamoya? We know that in Moyamoya means collaterals. The leptomeningeal collaterals that stimulate the dural perivascular nociceptors, and that leads to the activation of the trigeminal system. And that we know is the mainstay behind causing this kind of headaches. Another possibility of headache is a chronic cerebral hypoperfusion or a borderline perfusion as a result of progressive stenosis, because we all know the mechanism and it causes cerebral hypoperfusion and the occlusion of the major anterior circulation arteries. And there the ischemia, this may lead to cortical spreading depression. And we all know that the major player behind the migraine with aura and the aura mechanism is the CSD or the cortical spreading depression. So there are many moya patients who have typical migraine with aura presentation. And that is because of the microvascular ischemia and the oligemia that is leading to the CSD, and that is leading to the exact migraine-like headache presentation in this presence. And the vascular endothelial damage in moya disease and the related collagen exposure could promote platelet aggregation, and which was recently shown to correlate with intractable headache in these patients. And these patients were shown to improve radically on the headache aspect after giving aspirin. So that was a very important thing, and that is very much needed for therapeutics also. So because aspirin promotes this, this disturbs this platelet aggregation, and then can break the headache cycle in these patients. So there are two types of management in case of intractable refractory headaches in moya disease patients. One is medical, one is surgical. Currently, there are no studies which specifies that this is the particular medicine of choice for headaches in patients with MMD. For that, maybe future studies will come up or more data is required. However, the mainstay of medical therapy is to treat according to the phenotype of headache. If we remember, our patient, whatever we could document, had 8 episodes of migraine-like headaches without aura and 7 episodes of PTA. So our option will be to treat accordingly. We may treat according to the migraine-like headaches. Antiplatelet therapy, as I just now mentioned, because the platelet aggregation disturbs this mechanism and causes the headache, and so antiplatelet therapy may help in that aspect. Triptans are contraindicated, the dihydroergotamines are to be avoided, and NSAIDs are to be used with caution. So lasmiditan, which has been approved in 2019, can be well used in patients over 18 years in HAMD, headache associated with moya disorders. Now, chronic therapy is debated. However, agents that lower the BP, like propranolol, calcium channel blockers, they should be avoided in these cases. In our patient, we use divalproic sodium along with this aspirin, and this patient has got relief to a great extent right now. So we use this kind of things. We search the literature. There were few articles in the recent time, like this came up in 2022 in Cephalalgia, the evaluation and treatment of headache associated with moya disease. Because we are seeing many patients with moya syndrome or moya disease, and many of them come with headache, and we often overlook that because we are dealing with stroke, we are dealing with hemorrhages, infarcts, and we are not looking at the headache part at all. And we must remember that like our patient did, they presented with only headache. So we have to carefully see and carefully investigate. And when we investigate in MRI, source image is one of the most important parts of the films that we should look very carefully to find out whether there is any suggestion of moya disease. Again, there was a Chinese study which was published in Frontiers of Neurology, again in recent times in 2020, that determined the clinical characteristics and long-term outcome of headaches associated with moya disease. And it was in the initial part in 2010 that started the study of headache associated with moya disease with a case story and literature review that started with only one single patient and few other patients, and thus launched the further studies. Now, another important thing, if a patient is having refractory headache and moya disease, is surgery indicated to relieve the headache? So these studies, I took help of these studies only. This showed that revascularization initially improved headache in terms of frequency and severity in both pediatric age group and adult age group patients. However, a long-term follow-up showed that this surgical management in the management of headache only, I'm not talking about the vascular incidents, vascular accidents, they were more or less same as with respect to conservative management. So, interesting pointers in this case, migraine-like headaches can be a sole presentation of moya disease. Here, the multiple cranial nerve palsies with headache cannot be correlated exactly with the process. So, we thought that there must be some inflammation going on. Maybe we are not able to pick that up. Or maybe we are missing something. There is some underlying meningitis which is causing that, and we are missing that. Or maybe some underlying inflammatory process that is causing this cranial nerve palsy, headache, as well as the Moya-Moya syndrome that we are yet to pick. There must be some underlying inflammatory processes there. But apart from biopsy, we have done all the available investigations and still could not find anything. We are yet to do a PET scan to find out any source of inflammation, which will be done soon. And in this patient, can surgery be a solution to the bothering headaches or the risk of having this vascular accident? This patient definitely has a risk, but now the issue was headaches. So can it be a surgery? Because this patient opted out of surgery and said that I won't do surgery. And now the patient is a bit better on aspirin and chronic prophylaxis for migraine. But then again, a long-term management may be required. So my questions, my doubts in this case were the cause of inflammation, the relationship of multiple cranial nerve pulses, recurring that too with Moya-Moya, headache can be a presentation, and whether we are missing any inflammatory process. So thank you, and I'd like to opinion from teachers, Debashish Chaudhary sir, Ganguly sir, Dukal sir.
Thank you, Yasodhara, for a fine case. I think it's an interesting case, and I don't see yet any questions. Please kindly put your questions on Q&A box so that I can ask to. So one question has just come up. See that, first of all, your patient has got, the headache, which is a migraine phenotype, and you have deduced from the history that probably it is going into a chronic migraine phenotype, right? And then the patient also has got multiple cranial nerve pulses in the form of bilateral 6th and 7th. And he presents with this recurrent headaches with a neurological deficit. So obviously it's a secondary headache, right?
Yes.
So that much we are sure from the beginning, actually. Then you dig the past and you find that there was some episode 8 years back, and he did have headaches, and in between there was a doubtful period where he probably had some headaches but didn't have that much. So the question is this for you, that because there is a strong element suspicion of a inflammation that is going on. And when we talk about the inflammation, then there are chronic inflammations which can go on for years and produce this kind of picture, or there can be non-infective inflammation. So the first question, that can it be borreliosis? Did you consider possibility of borreliosis? Your proteins were slightly raised, but cells were 10.
Raised. Slightly
but
raised.
cells were 10. Right?
Yes, sir.
So,
Yes, sir.
So did you consider borreliosis? That is the first question.
No, sir, we did not actually consider, and also that would not have been possible to do because we did whatever the neuroviral, the infectious panels that were available, and we also did the, as you are saying, sir, the non-infectious inflammatory disease. Like we also did a sarcoid, IgG4 that are commonly seen. More or less, we did all those. But but borreliosis we did not do. We did up to strep typhus, this kind of things that are common in our part of the country, but this we did not do actually.
Yeah. Okay. So I think the uncommon chronic inflammatory conditions of infectious origin, they also need to be actually ruled out, and to say definitely that this is not a secondary vasculopathy because of the CNS, intracranial CNS vasculopathy because of infection. The second question was black blood imaging done?
No, sir. Black blood imaging was not done. Black blood imaging is mostly done to see the pathophysiology part, right? So we did whatever was available. We did a vessel wall imaging where the neuroradiologist told that there was no sign of active inflammation. So we did not do that, and that is not available. But we could have done it outside, but that was not done because we were more or less sure there is no active inflammation from them.
Okay.
And biopsy was also not done.
Right. So you see that when you have already shown that kind of chart where you have suggested the the differentials of Moya-Moya syndrome, and there are many conditions to actually deal with. But I was just wondering that did you rule out the metabolic causes like homocysteine metabolism, methyl
Yes, sir. We
malonic
sent
acidemia,
the panel.
propionic acidemia?
So we plan to send a TMS, GCMS now because we have finished all the normal investigations. So
Yeah.
now the pending things are TMS, GCMS to see the metabolic things, a PET scan to see rule out any other thing we have, and a biopsy.
Because the point is this, that it is also slightly difficult to explain, just because of the vasculopathy, the bilateral sixth and the seventh. So that does, show that probably there is a meningeal or a subarachnoid involvement, right? Because you are not seeing anything in the brain. But
No, sir.
unfortunately, your MRI is not showing any significant meningeal enhancement. So therefore, the case is very difficult to explain. So is it because of, your pressures were normal? So it's not because of the raised ICP. It doesn't have papilledema. So bilateral six, why there is bilateral six, why there is seventh, it is difficult to explain. So therefore, I think it will probably require slightly more, investigations and more thinking about the other possible things. But it's a very interesting case. And nowadays, now and then, we are now finding that a lot of patients are coming with this kind of non-specific vasculopathy. Where, see, the point is that so-called the puff or the so-called the collaterals, when there will be a chronic obstruction or chronic occlusion, the collaterals will develop. They will open up, right? It is the pattern of the occlusion that is going to determine that where, and as you rightly said, that moya would probably would be bilateral, more proximal, involvement. So therefore, the pattern will determine that what kind of. So I would rather kind of say that it's probably a probable moya syndrome bordering on other vasculopathies about which we need to further investigate. But it's a very interesting case. And so question is that, did you think that you didn't start any steroids for him?
No, sir. Actually, we did not know what to do. So initially, we thought that because after ruling out the infection, we could not find an immediate infection. So for that, we did give him a course of steroid, and the patient improved. That is that is again giving us a clue that this is something inflammation is going on. Because this patient improved on steroids. So some inflammation is going on, but we cannot find what it is. This is the crux right now.
So I think obviously the patient didn't agree for the brain biopsy. Obviously that is another impediment. But I think you can get ahead and do the metabolic profile and look out for, because sometimes this, rare metabolic syndromes can also present like this vasculopathies, and therefore it will be worthwhile, it can be a worthwhile pursuit to do that. But it's very interesting case, and actually it shows that whenever you have a headache case, so, in this case, you are lucky in a sense that the patient did have a frank neurological, symptoms and signs, right? Focal deficits, right? But in many cases, you will not find, you will just find the headache. And then you have to have a strong suspicion index before labeling them as a primary chronic migraine headaches. So this is basically a secondary headache with a chronic migraine phenotype.
Migraine, secondary and primary. Yeah.
So that becomes at times very difficult. So thank you so much. Please stay on the line. You might be, surprised by seeing the other cases, right?
So I'm on the line. Okay, sir.
So, thank you so much. Thank you.
Thank you, sir. Thank you.
So can I request the second speaker? So Dr. Ashwin Kumar Panda, he is a former student of mine and is currently the assistant professor, Department of Neurology at IBAS, Delhi. And he has done the specialty certification neurology, MRCP, in 2022. And Dr. Panda is going to talk about an interesting case in headache. Dr. Ashwin, please. And before you start, I just request everyone to kindly send questions and answers in the question answer box, because then only we can take forward the discussion. Okay, thank you.
Am I audible to everyone?
Yeah, yeah.
So good evening, everyone. I first of all thank my teachers, Dr. Devashish sir and Ashish sir, for the opportunity to present this unique case. And sharing this thing, yeah. So present this unique case. This case highlights the nuances of a rare entity, which we do not usually see in our practice, and whose subsequent management makes the study of headache a satisfying field. So we move on to the case. In this case, we will touch upon the brief history and examination. Then we will talk about the progression of the disease and the course of treatment in a little bit of detail, and then discuss upon those unique points that I was talking. So the patient came to us with a left-sided side-locked headache for a month. He came to us on January. So he started to have these symptoms in the December of last year. He was a 57-year-old male without any known comorbidities. The pain that he described was excruciating, with a visual analog scale rating that he gave himself of 10. He had around 10 to 15 episodes of such headache per day, and each of those episodes would last for 1 to 2 minutes. On further elaboration, he said that the pain would start predominantly in the V1 region of the trigeminal nerve, but occasionally it would spread to the V2 region, that is the cheek and the nose as well. It was touch sensitive. He said that while sleeping or while wiping his face or while bathing, he would trigger these attacks. And sometimes also while feeding, that is while by chewing onto food, there would be some intraoral triggers also, which would cause severe pain apart from the spontaneous pain that he used to have in the day. Along with this pain, he had a tearing from the left eye. So we asked him to elaborate on other autonomic features, and the family members said that tearing was the main symptom that he had along with headaches. But if he had like 10 to 15 episodes per day, occasionally on 1-2 episodes, there would be certain redness and some rhinorrhea. And he also had a restlessness with this. So with this phenotype that he presented to the OPD, it was fairly, certain that he has something kind of attacks, but what kind of attack that we had to see. So we went on for some further history. So this is a crux of the further history that we took. So apart from the 2-3 cranial autonomic features, there were no other cranial autonomic features. There was no pain in the VT distribution. There was no sensory loss, no motor deficit, no other cranial nerve involvement, or no danger signs, as in SNOOP 4. So no other signs which could say that this has a secondary nature to it. But still, keeping the possibility of a secondary attack, so the examination was done. We found that yes, he had a trigger which, when touched on the forehead and sometimes on the nose, would cause excruciating pain. But there was no apparent refractory period on this. The extraocular movements, the fundus examination, the other neurological examination was normal. On imaging, we did an imaging to look at the pituitary cuts for any lesions. We did imaging to look at any pachymeningitis, and the imaging also had a look at the trigeminal vascular bundle for any vascular loops that could cause a trigeminal neuralgia. The Fiesta sequence and the Swiss sequence also gave out a normal. So by the history and the examination, we thought that yes, it's a short-lasting unilateral neuralgiform headache, SUNA, according to the ICSD-3 diagnosis. And probably it is one of those two entities, SUNCT or SUNA. We were banking more upon SUNCT because of the conjunctival redness and tearing both being present in the patient. So now what happened is that course of treatment and disease. So, he came to us on January. So we started him on the usual drugs, that is lamotrigine and oxalic. So we started him on 150 milligram OD and then subsequently increased it. And similarly, we did the same with lamotrigine for the 2 weeks. We thought that yes, the pain would probably subside. But in the next 3 weeks, we had to increase the drugs to 300 TDS. Lamotrigine was increased to 50 BD from 12.5 milligram OD, and we have also had to add gabapentin 300 milligram TDS because there was a significant change in character of pain, and the pain started to become so disabling that the person could not do any of his activities of daily living. So what happened? So earlier when he came to us, as I said that he had 10 to 12 episodes of these kind of headaches a day. So they were lasting from 1 to 5 minutes. So these are the two graphs that we had made out from the history. We had actually showed him some of the graphs from the literature, given him the graphs, and he had gone home and came back with the homework himself. But these are the graphs that we have got out from the detailed headache chart and history. So the pains used to last for 1 to 5 minutes. So those ones which lasted for 1 minute or 2 minutes, they were like single stabs, severely excruciating pain of Vasco 10 with a interictal period of no pain, and then again episode. So as the pain duration started to increase up front, 1 minute, if the pain was lasting for 5 to 6 minutes, then it caused a plateau. So these were the two pattern of pain that he came to us in January. By the time it was February, he now started to have longer attacks and the increase in the number of attacks also. So there were 35 to 50 attacks per day, sometimes 10 attacks an hour, 15 attacks an hour, which widely varied from 5 minutes per attack to 20 minutes per attack. So when it started to go to 20 minutes per attack, and with the history of a slight interictal pain and intraoral triggers, we were actually thinking about the possibility whether we are dealing with a SUNCT or a trigeminal neuralgia, trigeminal neuralgia form type 2. But if you look at the graph here that the patient drew for us when he was admitted with us, he said that those pains which used to last for 20 minutes, there would be a sudden rise in the pain and there would be a plateau in between, not considerably decreasing the pain, but slightly decreasing and then rising. And each of these stabs would last for 1 minute or 2 minutes, and this will keep on going for 20 minutes. In between these two severe pain attacks, there would be a dull aching pain on the same side of the head, that is the left side of the head, associated with some vomiting and nausea. So as I said, he came to us in January. We started him on medical treatment, lamotrigine, oxcarbazepine, and gabapentin. And in February, he had some change in pattern, increase in duration and frequency of headache. So we decided to give him something in the form of intravenous lidocaine or a greater occipital block. So he denied a lignocaine infusion because of the side effect profile that we told him. So we had no option because of the excruciating pain that he was going through to give him a greater occipital block. So we gave him a 80 milligram methylprednisolone with 2 ml lignocaine on the left side, the unilateral side. And within 48 hours, he had 0 attacks. He was an excellent responder in the form that the headache intensities and the attacks would decrease more than 90%. And it was a drastic effect that the Gon block had on him. Further, for 1 month, he remained pain-free. That's from 4th of February to 7th of March. Again, in March, the headache started, 4 to 5 attacks per day, small in duration. And by the time it was April, the attack duration and the number of attacks started to increase. During this point of time, we again started to rely on the medical treatment and we increased the drugs again. Oxcarbazepine was increased to 400 milligram TDS and lamotrigine was also increased. Because of the drugs, we started to have some ataxia and occasional vomiting. So we decided to go for another Gon block on 19th of April. This time it took him around 4 days. So slowly, gradually, his number of attacks decreased and he had 0 attacks by day 4, along with decrease in touch sensitivity also. So we last met him on 29th of May and he was pain-free then. He's saying that now he started to have some mild attacks, 1 to 2 per day, but they're very mild in the VAS scale and the duration is also small. The summary of the case is that yes, he had a SUNA probably because we kind of ruled out major secondary causes via imaging and probably a SUNCT because of conjunctival redness and tearing. He had 3 patterns of this headache. So this is a nuanced thing. Sometimes the longer duration of headaches can confuse you in a male to think about cluster headaches. Interictal pain can push you towards thinking that it is a migraine, not a SUNCT or a SUNA, because sometimes the redness and tearing might be there in migraine patients also. This patient was a non-responder to medical therapy. He also had some intraoral triggers which confuses the diagnosis. He did not respond to drugs, had some side effects with it, but he had an excellent response to Gon block twice. So we discussed the unique points, that is how to reach to a diagnosis of SUNA, how to further classify them, what are the usual distributions and what are the unique distributions, what are the patterns of SUNA and what is the utility of Gon block in such patients. So these are the primary references. I would not be putting down the references for each of the slides that I have made because this is a consolidation of the major papers that I've gone through. These are 5 papers which kind of put the things into perspective and would answer most of your queries on something. So we begin with the first question. So how do we make a diagnosis in headache and in cricket? Timing is important and a detailed history is also important. So take a detailed history and the timing of the headache and the location of the headache time point out to you what symptoms or what syndrome is having. ICSD-3 classification, actually remembering it or keeping it on the bedside guides the interview and helps you to ask pertinent questions to arrive at the diagnosis. Like in this case, the patient should have had 20 attacks, moderate or severe unilateral pain, which is generally orbital, supraorbital, temporal, each lasting for 1 to 600 seconds and occurring as single stabs or series of stabs or a sawtooth pattern. Out of the 7 autonomic features, the patient needs to have 1. That can be conjunctival injection, nasal congestion, eyelid edema, forehead swelling, forehead and facial flushing, sensation of fullness in the ear, meiosis, ptosis. The frequency should be at least 1 per day, and it should not be accounted for other ICSD3 diagnoses like secondary headache. So now SUNCT or SUNA. So if the patient fits into SUNA, you move towards either of the two. So as far as the ICSD3, if the patient has both conjunctival redness and tearing, it would be labeled as SUNCT. And if it has only either one, then it is labeled as SUNA. Here, as a treating physician and as a neurologist who's asking the patient these questions, the conjunctival redness actually was very few in between. If he had like 50 attacks per day, 5 or 4 of them would have conjunctival redness. So there is still a question mark on what I would like to ask sir and other senior teachers about it. What is their thought process on it? Now the distribution of pain. This is a table from Lamrao et al. It's a case series of theirs on SUNA and SUNCT. So they list out a lot of regions from where the pain can start. So generally it is unilateral, but in 11 to 15% of the patients, it can be alternating. That is, during one phase of the attack, episodic SUNCT, during one phase, it might be on the left side. The next year, if it starts, it can be on the right side. So it can be alternating. Generally, the territory of pain is V1, but it can start from V2 and V3 also, as you see in the list on the right side. And the sites can be extra trigeminal too. What are the cranial autonomic features, whether it can differentiate between the two, SUNCT and SUNA? Well, the authors say that SUNCT patients have more prominent autonomic features. So of the 7, you will find probably 2 or more or 3 or more in SUNCT patients, whereas you will find only 1 or 2 in SUNA patients. SUNCT patients are seen to have more ptosis and conjunctival redness and rhinorrhea. So in a sense, the pain, if it originates from the V1 area, the patient is bound to have more redness and lacrimation. And if it originates somewhere around in the V2 area, rhinorrhea and nasal blockage are seen. Third important point in this case, nuance in this case, was the touch sensitivity. Now, so touch sensitivity sometimes confuses us and it takes us towards neuralgia, and it is one of those things that one needs to differentiate. So, touch sensitivity, when touching the face, the patient had this, and also intraoral, as I said. It was in addition to the spontaneous attacks. Of the two, that is SUNCT and SUNA, SUNCT patients have more triggerability. So there is a thing called refractory period that can be used to differentiate the SUNCT from trigeminal neuralgia. Wherein you trigger that pain, it increases, it triggers the attack, and you wait for that pain or the attack to subside. As the attack subsides, you trigger it again by the touch. And if there is no refractory period, you could easily say that, okay, this is more likely to be SUNCT and not likely to be trigeminal neuralgia because they have a refractory. Sometimes SUNCT and SUNA patients can also have refractory periods that can last for 2 to 5 minutes. This is a thing that I've taken from one of the articles by Chaudhary et al. They have based this picture on Pajera and Cohen et al. They have mentioned of 5 kinds of patterns that 3 and 5. There are 2 that can be there. There is a sawtooth pattern and a repetitive stab pattern. So these are the 5 patterns that can be there. So one needs to be cognizant and aware of this. And I was saying that if you show this chart and graph to your patient, he would be bound to describe his headache a little better and help you in your diagnosis. So in terms of the patterns of pain, interictal pain can be present in patients. They can have migrainous features like vomiting, photophobia, and phonophobia. Visual aura sometimes can be present, but it's very rare. In a series of 78 patients, I think 2 or 3 had in Lamrao et al. There is another entity called a status SUNCT or SUNA, wherein a case was published from GBPAN, wherein a patient of status SUNCT was given intravenous lidocaine and he responded well to that. So the authors have mentioned there that status SUNCT is when there are 30 attacks per hour and it completely disables and breaks the patient into a state of he decided not to push for an intravenous lidocaine and went to a gone block. So before going to gone block, we did our literature search on it, and we found a single arm meta-analysis, also a cohort of 78 patients by the authors. They had used the same doses that we used, that is 80 milligram MPS and 2 ml lignocaine. They also gave unilateral blocks, so unilateral blocks on the side of headache seemed prudent. In the study, they found that there was good and excellent benefit. So a good benefit was seen that there should be a 50% reduction in the pain, and excellent benefit 90%, more than 90%. So 27% of the patients had that. The were pain-free between 10 to 30 days, and 35% were pain-free from 1 to 5 months. The mean of duration that mentioned in their paper was somewhere around 41 days plus minus 34 days. In their paper, they said that SUNA patients respond a little slightly better than the SUN patients. Our experience from this case is that this patient responded really well to gone block, dramatic response. His trigger ability decreased. He became pain-free. There was a tremendous improvement in his quality of life. And we were also now able to decrease the doses of medications and reduce the side effects of ataxia and vomiting. He is now vomiting free. Mild ataxia persists because of the carbamazepine dose that he is on. But hopefully, with the lower doses, that will also go. So in summary, SUNCT and SUNA may sometimes be difficult to differentiate. And occasionally, it might be a problem to differentiate them from trigeminal neuralgia also. Some authors do believe that probably these things have the same pathophysiology going on under, so they might not be very easy to differentiate in terms of phenotype. But pattern recognition does help in avoiding misdiagnosis, and unilateral gone block can be tried as more than a transitional treatment. It is being used as a transitional treatment in a sense that gabapentin and carbamazepine or lamotrigine, those can be increased because we can't increase them in a jiffy. So take around 2 to 3 weeks to increase the dose. Gone block can help us to tide over that period. But I think the experience in this case is that if the patient has a pain-free period for say 1.5 months and 2 months, so why not use gone block as one of the primary treatments along with pharmacological treatment? Thank you very much.
Thank you, Ashwin. Thank you for a very nice presentation. I think, yes, gone block, because I have got a very personal interest into the procedure. So I would be speaking a little bit more on that. But first, let us tackle the questions that you have for you. So somebody said, obviously it's difficult actually, not only the cluster, but I think paroxysmal hemicrania also. So how will you differentiate that? At times it might be difficult, and as you have rightly explained. So that is one part. And secondly, was there any exposure to paint or change of toothpaste?
So I'll answer the second question first. No, there was no exposure, any toxin exposure of any kind. He's a 57-year-old male, fairly resides at his home. So no change.
Yeah. So he is asking this question because there has been Thomas Matthew from the south has actually had few patients who were having this with the application of balm and changing toothpaste and things like that, and so that can actually deter. And you said that there are some intraoral triggers for this patient.
Yeah.
So did you ask that was there any change, like some local toothpaste with this? Now a lot of Ayurvedic products and things like that come in. Okay, right. And
to be very honest, we have not asked about the toothpaste thing.
Yeah.
But as far as the paroxysmal hemicrania and the trigeminal neuralgia thing is concerned, I agree with the people asking this question,
right,
that it is sometimes difficult to differentiate. But I think the pattern that the patient was elaborating by himself, the kind of attack that he was describing, and the restlessness, the graphs that he has made, it fairly fits into Sanktan Suna. So we thought to go ahead with that diagnosis and give him the most appropriate treatment at that point of time. Because when he came to us with those 50 attacks per day, it was very difficult not to give him anything. He was in a depressive state. So
That's
And,
well taken. You have to treat the patient, and obviously the the phenotype was of Sunha, as you say. We'll talk about the differentiation somewhat later, but that is very important that you should treat because they are extremely debilitating pain and they are actually crying for help. The second question for you is that was there what is the relationship of hypercarbia and headaches? Especially. I mean, he has not mentioned it, but probably he is meaning that hypercarbia and tax-like feature. So, any input or from your side, or should I? So,
Sir, I think this question should be tackled by you.
Yeah. So, I think that carbon dioxide or carbon monoxide, they do when they accumulate in the body, they do cause headaches, and the headache character and the headache phenotype may be tension type headache or a migraine type of headache, or even occasionally it can be a kind of attacks, though very rarely they have been described. But carbon monoxide poisoning and the carbon monoxide accumulation is a prominent cause of headache, and especially if you are residing in a area which are cold and where you use a lot of in-house heating elements. I had seen about 3-4 patients from the Northeast where during the winters they put up those heating things in a closed door environment, and partial burning releases a lot of carbon monoxide, and these people usually have an early morning headaches, and way to diagnose that is to do a carbon monoxide level by carbon monoxide meters, oximeters to check for that, which is unfortunately not available in many places. So yes, there is definitely this thing. In cases of COPD or in cases of there is a carbon dioxide retention, they also complain of a lot of headaches. And many a times we had the occasion of seeing patients with a COPD who goes into remission and then exacerbations. They keep on having a headache as a predominant prodromal symptom of a hypercarbia. So therefore, this is also again a good question, and I think everybody should be aware of that.
I mean, sir, just to add on a point, do hypercarbia patients have TAC-like features? But generally, I think they have tension type headache.
Yeah, so they generally have a tension time and occasionally migrainous features, and especially it depends on if they are having a baseline, migraine headaches already. So there, that migraine phenotype gets exacerbated because of hypercarbia. And the third thing would be a situation where you have decreased oxygen rather than hypercarbia. So that can happen in high altitudes and also as a component of sleep apnea. So any persons who are having this refractory headaches, so you should always look for a sleep apnea, because that's a correctable thing which you can do. And there predominantly the hypoxemia is responsible, the character. And the character may again look like a TTH or a migraine phenotype. So generally my approach is to actually characterize the phenotype of the headache rather than labeling them as TTH or migraine, then work on and see that whether they are actually the primary headaches or they are just there is a secondary cause hidden behind it. So another question for you, that is there any overlap between different types of tags? We see quite often patients of cluster getting converted into PH. So he has opened. What is your experience? Probably he's meaning me, what is your experience with SUNT2?
My experience as compared to is limited, but I can say that in terms of SUNT, SUNA, and TN, yes, there is a lot of overlap that one can see. Sometimes it is difficult to differentiate the three. But I've in my personal experience, I've not seen a cluster get converted into paroxysmal hypercapnia. Any experience of yours, sir?
Right.
Maybe.
No, so no, we this is a definitive kind of a problem that tags, they often change. And more commonly, there are two, defined syndromes. One is paroxysmal hemicrania going into a cluster phenotype, or a cluster phenotype going into paroxysmal hemicrania. That is well known. And also that you have got the cluster tic syndrome, that where the patients of cluster headache will also have a trigeminal neuralgia, because you have to be very careful, because there are cases of facial cluster, like the cluster actually originating not so much in the head but on the face itself. So there at times it becomes difficult that cluster with tic syndrome versus cluster with the facial origin. So these kind of overlaps are there. Now, as far as this classification, I think the SUNHA, SUNHA, which is the broad rubric under which these two groups are, the SUNA and the SUNT, are included. So the basic concept is that probably the SUNA is the broader category where you don't have the conjunctival injection, and there will be a subset of patients who will have a conjunctival injection, and they will be called the SUNT. Actually, from my point of view, there are hardly any, in terms of the disease characterization, disease severity, and the prognosis and the management pattern, there is hardly any difference between the two, except for the fact that there are some practical issues, like whenever the patient comes to with unilateral, headaches with autonomic symptoms, without redness, without conjunctival injection, so they will complain less of that unless you extract those cranial autonomic symptoms. They will say that one-sided eye pain. They will say completely that there is a severe pain. So there are chances of labeling it as a trigeminal neuralgia is much more compared to patients who are overtly presenting with conjunctival injection, because then the physician knows that conjunctival injection is not so common in trigeminal neuralgia, occurs in less than 1% of the patients. So therefore, the diagnosis becomes much more clearer. Most of these cases of SUNT and SUNA are actually diagnosed as trigeminal neuralgia, as you know, that they are the commonest diagnostic, diagnosis that is given. So this, I think, is more of semantics, and probably there exists a pathophysiological basis in distinguishing why that some patients does have conjunctival injection and why others they don't have. They have just the tearing and only the lid swelling or the facial swelling or the ptosis. So we don't know yet. It is basically the autonomic reflex arc and its activation. So I'm not sure that I have read anything new in this, that how do actually this get differentiation. And your point is well taken, that many a times patients may switch, and we have got now a very large number of SUNT and SUNA cases in our database. So we have seen that the patients switch from a SUNA attack into a SUNT attack sometimes, and sometimes SUNT attacks become SUNA attacks in the course of the disease. So therefore, don't get very, very fixated that no, it is SUNA and therefore it cannot be SUNT. But they can interchange often within an attack. Some of the attacks may be of SUNT type and some of the attacks may be SUNA type, or even outside the attack. I mean, even a period of time that phenotype may change. So I think it's more of a kind of a semantic thing, which is very important. Another thing is, of course, how to taper off indomethacin in hemicrania. And then this is another important character. This thing, that is there absent refractory period mandatory for diagnosis of SUNT? Ashwin.
No, it is not.
No,
it is not
it is not
mandatory. No, but it is an added clinical clue to help you to kind of differentiate it from trigeminal neuralgia. Although literature also says that SUNT and SUNA can also have a refractory period, although it can be small from 2 to 5 years.
Yeah, I think.
Mostly
I think Dr. Vimal Palial from SGPGI has published a paper in which he has shown that there were, I think, 3 patients who had, it was not absolute refractory period absent. So therefore, that is not an absolute criteria. But it does, is one of the features along with others which will distinguish between trigeminal neuralgia and SUNT and SUNA. What is the role of topiramate in SUNT and SUNA?
It is mentioned as one of the drugs, but the pooled database suggests that lamotrigine, oxcarbazepine, and gabapentin are the preferred things. But yes, topiramate can also be used.
Yeah, I think that one can, in some cases, topiramate can be has been tried anecdotally. So see, I think one thing a caution, Ashwin, is that some patients usually have a chronic course. The phenotype is usually the chronic ones. So even if they respond for a while to your drugs, then eventually they will have breakthrough attacks. And our experience has been that it is difficult to treat these patients because they will be your long-term friends. They'll keep back coming to you. They will have a good period for about 2-3 months, and then again they will start having this attack. They will come back. So be prepared of that. Yes, Gonblock is a very good alternative, a kind of an OPD procedure which you can do at that same time in the same sitting. And why not? I think I would recommend that in a first instant, before lamotrigine even, if the patient has come and if you have access to Gonblock, you can give the Gonblock to kind of prevent this thing, along with, of course, the lamotrigine, because lamotrigine needs to be built up slightly slowly, and therefore it will take some time to be built up. And of course, in some patients, you might have a very long remission periods of about 1 month, 2 months, 3 months. But then I'm sure that these patients are going to come back to you after some time. So don't leave these patients. You have to actually follow. And
one question that I wanted to ask you, sir, is can you try Gonblock on all of those exacerbations and kind of do away with the
we are now in a process of publishing about 3 cases where recurrent repeated Gonblocks were actually helpful, and one of the patients actually had several stints in ICU with a lignocaine infusion also, but then it would come back, and every time you cannot actually admit that patient so this patient is now prophylactically on a regular 3-monthly Gonblock, and with of course oral medications, and he is doing better. So there are this will be that's why I said they are long-term friends, and they are going to come back to you. So if you need to take care of them. And finally, there is a question about how to taper endomethacin in paroxysmal hemicrania or hemicrania continua. That is slightly besides this case, but I think
I've typed the answer. I've typed the answer too.
Yeah. So you will take that question probably slightly later. Okay, right. So can we go to the last case? Thank you, Ashwin, for a very interesting case and informative case. And we go to the last case by Dr. Apurva Tomar. And yeah, so Apurva had been my student, and now she has passed out, and she is practicing neurology at Meerut. I think she has created her own hospital there. We saw this interesting case long time back, I think 2 years, 1.5 years back. So when Apurva with us, so Apurva is going to talk about that. Okay, yes. Apurva, please.
Thank you, sir. Good evening. Thank you, my teachers, Dr. Debashir sir and Ashish sir, for giving me this opportunity to be presenting this interesting case here. So I'm presenting a case of 20-year-old male without any previous comorbidities who presented to our OPD with the complaints of episodic headache for the last 1 year. The patient would complain of this headache for the past 1 year. Initially, the headache was episodic, occurring at 1 to 2 month interval, and the headache frequency progressively increased for the past 2 months post-COVID vaccination. He complained of near daily to every alternate day headache. These headache episodes would occur around 10 to 15 episodes per month, and the duration of each headache episode would last for around 30 minutes to 2 hours. The headache would build over 15 minutes to moderate to severe intensity of VAS 8. This headache would improve spontaneously or after rest over 15 to 30 minutes. The patient would complain of holocranial headache, worsening in character. It was associated with phonophobia with occasional nausea during these episodes. These were not associated with photophobia or vomiting, without any cranial autonomic feature or signs of raised intracranial pressure. The patient would often complain of restriction of activities during these headache episodes. Headache was not precipitated with coughing, sneezing, Valsalva, or with postural variation. There was no complaint of any recent change in character of headache, although the frequency of headache had increased. He did not complain of any systemic symptoms in form of fever, weight loss, or any constitutional symptoms. He did not complain of diplopia, blurring of vision, pulsatile tinnitus, or TVOs. There was no history of pain that disturbs the sleep or presence immediately on awakening, and there was no complaint of vomiting preceding these headache episodes. On asking regarding his past history, the patient gave a very peculiar history of recurrent episodes of transient weakness of limbs after eating hot and spicy food. Then we asked a detailed history. The patient would complain of the recurrent episode of these transient weakness of limb for the past 3 years. He would complain that it would occur while eating hot and spicy food. The description of the events by the patient was as such. The patient would state that these episodes would start as numbness of upper limbs and lower limbs, which he described as inability to feel normal sensation. He could not feel any pinch in his limbs at that time. This was associated with the inability to grip objects, slippage of objects, and sometimes he could only hold his upper limb against gravity and could only momentarily lift his upper limb against gravity. And sometimes he could not lift his lower limbs or fall on attempted attempts and remain bedbound during these episodes. The total duration of these episodes will last for around 10 minutes, and these were followed by a full recovery after these events without any residual deficits. The patient remained fully aware of surrounding and remained conscious during these episodes. These episodes would occur on and off, and these attacks stopped since the patient has stopped eating hot and spicy food with no further attack for the last 6 months. So this was the history that the patient gave.
मेरा नाम अभिषेक है, मैं 20 साल का हूँ। पिछले 3 साल से मुझे एक तकलीफ है कि जब भी मैं खाना खाता था, उसमें जब ज्यादा मिर्ची खा लेता था तो मेरे हाथ पैर काम करने बंद कर देते थे। तो मतलब मेरे को कोई पिंच करता था या हाथ पैरों पे मारता था तो मेरे को पता नहीं लगता था, और मेरी ग्रिप भी नहीं बनती थी। फिर कुछ चीज उठाता था तो वो अपने आप छूट जाती थी, और चलता था तो मैं गिर जाता था। और इस दौरान मैं मतलब सब कुछ किसी दूसरे की बात समझ भी लेता था और खाना भी खा लेता था, उसमें मेरे को कोई तकलीफ नहीं होती थी, मैं दूसरी की बातों का जवाब भी दे दिया करता था।
There was no history of any vertigo, dysarthria, diplopia, or loss of consciousness during these episodes. There was no history of any visual, sensory aura or any associated headache. There was no history of weakness precipitated after exercise or rest after exercise. There was no history of weakness occurring after taking sweet or carbohydrate-rich food. There was no history of pain or cramps associated with weakness. There was no history of any diurnal variation in the episodes of weakness. And there was no history of any extraocular muscle involvement or ptosis associated with this weakness. There was no history of heat intolerance, unexplained sweating, palpitations, or diarrhea. There was no history of loss of consciousness, tongue bite, or incontinence during these episodes. There was no history of any post-weakness confusion or amnesia. And there was no history of any provocation with sudden neck turning, sudden coughing, sneezing, or performing Valsalva. Other past history was insignificant. In the personal history, there was no addiction. He had a normal sleep bowel bladder pattern, and he had a normal birth and developmental history. So to summarize, this was a 20-year-old male who presented with complaint of episodic headache, probable migraine phenotype since 1 year, with a significant past history of recurrent episode of transient weakness of limbs, which were provoked on eating hot and spicy food for the past 3 years. This was not associated with any residual deficit, seizures, cognitive decline, any diurnal variation, any worsening with exercise or rest after exercise, and there was no muscle cramps. So after taking the clinical history, the clinical localization after history, for episodic headache, we suspected patient had a probably secondary headache. So there were 3 pointers towards the secondary headache. First, the shorter duration of headache that was atypical for migraine. The second pointer was exacerbation following the COVID vaccination, that is increase in frequency post-COVID vaccination. And the third pointer was a past history of other neurological symptoms that was again suggestive of some underlying secondary headache. The clinical localization of episodic weakness of limbs would be to cerebral cortex, brainstem, CV junction, cervical cord, neuromuscular junction, or a muscle such as channelopathies. So we kept these possible etiologies for recurrent and transient quadriparesis, such as recurrent posterior circulation TIA, CV junction anomaly, cervical canal stenosis, cervical spinal cord AVM, channelopathy, hemiplegic migraine, and functional. After that, we did a clinical examination. His vitals were stable. All the peripheral pulses were palpable. He had no carotid bruit. And we, on a general examination, we found that patient had a short stature. Further head-to-toe examination was suggestive of a very significant finding. He had dysmorphic faces in form of hypertelorism. low set ears. He had a depressed nasal bridge and a small chin. We also found that the patient had some skeletal deformities in form of pectus excavatum and scoliosis. Other deformities such as winging of scapula and knock knees were also noted. On a systemic examination, his cognition was normal with MMSE of 30. Cranial nerve examination was also normal. And his other examinations, such as motor examination, only revealed a mild increase in tone. Rest motor examination, sensory, cerebellar, and other neurologic and systemic examination was normal. So, diagnosis after examination, we suspected some underlying genetic syndrome based on 5 features such as dysmorphic faces, short stature in our patient, chest wall deformities in form of pectus excavatum, scoliosis, and winging of scapula. So I'll be describing a very rare syndrome, that is Noonan syndrome. This was described after Dr. Jacqueline Noonan. She was a pediatric cardiologist, and she noticed that children with a rare type of heart defect, such as pulmonary wall stenosis, had a very characteristic physical appearance in form of short stature, webbed neck, wide-spaced eyes, and low-set ears. And she presented her first paper in 1963 on this condition, and this condition was officially named as Noonan syndrome after her. So what is Noonan syndrome? This is the diagnostic criteria of Noonan syndrome, and there are basically 6 features in which we should have at least definitive one feature, that is facial, typical faces. In our patient, the patient had a very typical face in form of facial dysmorphism. And again, another feature, the patient had a short stature and chest wall deformities. So the patient was fit in the clinical diagnosis of Noonan syndrome. Then we ordered the investigation to in suspecting some secondary headache with transient episode of quadriparesis. On a routine examination, the blood investigations were normal. The other investigations such as lipid profile, other autoimmune profile, metabolic profile of this patient was also normal. There were spinal deformities that were noted on X-ray as well. He had other deformities in form of short first toe. So suspecting some secondary headache, we did an MRI image. First, on seeing the MRI grossly, it was found to be normal. Then on a closer inspection, we found that the patient had small subcortical infarcts in the right frontal region, as well as had some linear streaks in the sulcal spaces on axial flare images. So this sulcal hyperintensity in bilateral frontoparietal area that are seen on flare and T1 contrast was suggestive of IV sign. So these was the MRI finding. That was there was some old lacunar infarcts noted, and there was sulcal flare hyperintensity which was noted, which is suggestive of IV sign. So suspecting the possibility of moya, we did an MR angiogram of this patient. On this, we found that the terminal part of ICA was stenosed, as well as part of MCA and ACA was also stenoid, and there were multiple collaterals that could be seen. So we ordered a digital subtraction angiography, and this was the screenshot that was seen when the dye was injected in the ICA. So in this, as we can see, when the dye was injected in the ICA, there was stenosis of the terminal segment of ICA, and there's poor filling of the MCA, and there were multiple collaterals that were seen, giving a puff of smoke appearance. So these were the findings of DSA, which is suggestive of moya syndrome. The patient had in the right ICA, MCA flow was absent with filling of cortical vessels from posterior circulation, and ACA flow with puff of smoke appearance was seen. And it was seen that the patient had a more restricted flow on the right side as compared to the left side. Other investigations were then ordered to look for other deformities, as we were suspecting some underlying genetic syndrome. We did a 2D echo in which mild pulmonary stenosis was also reported. Suspecting these transient episodes of quadriparesis and some CV junction anomaly, we also got a CT cervical spine CV junction done that also came out to be normal. And then we also ordered a genetic test suspecting some genetic syndrome, and in which a genetic mutation of PTPN11 with heterozygous variant pathogenic for Noonan syndrome was detected. So a final diagnosis of genetic syndrome, that is Noonan syndrome, with moya syndrome presenting with episodic headache, probable migraine, with recurrent TIA provoked with hot and spicy food was made. So after seeing this case, there were 3 questions that were raised. Was there any association of Noonan syndrome with moya syndrome? Was there any association of Noonan syndrome with moya syndrome with headache? Was there any relation of episodic weakness in moya angiopathy after taking hot and spicy food? So answering the first question, after reviewing the literature, we found various case reports in which spicy food triggering the clinical symptoms of moya angiopathy has been reported. And there were two hypotheses that has been quoted. That is why spicy food triggers clinical symptom in moya angiopathy. It has been reported that hyperventilation is the key factor that is precipitating the neurological impairment after taking hot and spicy food. That is, hyperventilation causes hypocapnia, resulting in vasoconstriction, vasospasm intracranially, thus reducing the blood flow to already susceptible cerebral areas, resulting in clinical features such as TIA and seizures. The other hypothesis is that after we eat hot and spicy food, it usually increases the blood flow locally in mouth by stimulating the transient receptor potential vanilloid mediated vasodilatation. And thus, this results in increased blood flow through proximal branches of external carotid arteries supplying the oral glands and mucosa, and decreases the blood supply from collaterals from ECA to ICA, resulting in ischemia in already vulnerable cerebral areas. So these are the two hypotheses that has been quoted in various papers. The other thing, the pathogenesis of headache associated with moya disease. So this entity already has been told, that is HAMD, headache associated with moya disease, has been recorded in ICSD-3 classification also. There are basically 4 pathogenesis of headache. First, the progressive intracranial stenosis in moya resulting in cerebral hypoperfusion, causing oligemic state is one mechanism. The second, very important, is dilatation of meningeal and leptomeningeal collateral vessels, which stimulates the dural nociceptor. The third mechanism is presence of cerebral aneurysm and AV malformation in moya disease, which may account for headache in at least some subset of patients by 2 possible mechanisms. Either stretch of the nociceptors by the enlarging aneurysm, or second mechanism is by sentinel aneurysmal bleed into the subarachnoid space. And the fourth mechanism that has been quoted is the neurogenic inflammation. This is a recent paper that has been published in 2022 on the treatment of headache associated with moya disease. In this, it has been reported patient with moya can have various type of headaches such as migraine, TTH, even cluster headache has also been reported in such patients. The third question, that is, was there an association of moya and Noonan syndrome? Although it is a very rare association, a few case reports has been published that has been reported. So this is the case of moya syndrome in patient of Noonan syndrome that has been reported so far. The fourth, was there an association of moya syndrome and TIA? This was again a paper in which the pediatric patient with moya disease, the event of TIA was recorded, and it was seen that 55 patients, that is 91.7% patient, had recurrent TIA. So TIA is a very common manifestation of moya syndrome. And the most important, what is the difference between moya syndrome and moya disease? So patient with the characteristic moya vasculopathy, who has a well-recognized associated condition such as Down syndrome, are categorized as moya syndrome. And patients with no known risk factor are said to have moya disease. So to simplify, when we use alone without the distinguishing modifier of disease or syndrome, moya refers solely to distinctive findings seen on a cerebral arteriography, which is independently of the cause. So what we have learned from this case, that we should have a holistic approach. Our patient presented with 3 features, that is headache, recurrent TIA, and dysmorphic feature, which led to our clinical diagnosis. So take-home message: headache can be associated in 63% patient of moya angiopathy. It's a common presenting symptom. Moya should be kept as a possibility in patient presenting with transient quadriparesis without loss of consciousness. Hot and spicy food can be a trigger for clinical symptoms in moya angiopathy. One should be very vigilant during general physical examination and should especially look for dysmorphic facies, skeletal deformities, which might indicate some syndromic diagnosis. And the subtle sign on MRI, such as IV sign, can give us a clinical clue for a moya angiopathy and has to be looked for. Thank you.
Thank you. Thank you, Apurva, for a very lucid presentation. And now I think you have got a few questions.
Yes.
First is that, was there any history of Zika symptoms in this patient?
No, sir.
Okay. So another thing is that whether is there any relationship? Of course, this is from, I think, previous Ashwin to Ashwin. Is there any relationship between premature cataract and cluster headache? I am also not sure about this.
I'm not sure. Not come across this.
No, really, Dr. Surendra, that I think if you have something, you can type it and we can know about it, but I'll look into it. It's a premature cataract. By that, you mean that just premature cataract or some genetically determined cataracts that have occur prematurely. So we need to look at that. And of course, there's a question of a headache and MCA dissection. So the dissections are common in migraine. In fact, migraine patients are at least 2.2 times have a greater odds of having dissection. So always when there is a change in the phenotype of migraine suddenly, and if you are having, say, for example, Horner's, sudden onset Horner's, facial pain, you should suspect a dissection in migraine patients. So that's there. I think this case of Apurva actually is, an eye opener, because I think this shows that, headache medicine is not just, dealing with the headache, but it is a all-compassing, subspecialty where all the other neurological disorders would also come in and make their contributions. And, at times it might be difficult. Now, this patient had presented with headache, but actually on asking, he had this, neurological symptoms, other symptoms. And then, of course, on investigation, we found something else. So always there is a quest for neurologists to ask more, to find out more through examination, and to investigate, to find out the hidden elements that are there. And that's why it becomes so important. And that's why the headache medicine gives you an entire, kind of entire landscape through which you can visualize various neurological disorders, be it stroke, be it movement disorders, be it multiple sclerosis, be it seizures, so all types of things will come with headache disorders, and sometimes they coexist with primary headache disorders, and sometimes with a secondary headache disorders as a part of a secondary headache disorders. So one has to be always in a learning curve, and we learn every day. So I think there are no more questions. So Dr. Ganguly, you can give your concluding remarks, and we can call it a day. Professor Ganguly.
Thank you. Thank you, our speakers for their excellent case presentations, and also the case of this, except the question is the two cases that with this MOAMA syndrome, that is the very, very good thing. One of the
so coincidental to MOAMA in the same day,
same day, and that is the one is the genetic, and we have seen the fantastic case of the Noonan syndrome. And this Yashodhara's case is also excellent. I think what you have already mentioned, that to present this case, publish this case, you have to rule out borreliosis. We have to do this borreliosis to rule out lab test of this borrelia to rule out this thing. That will be a good case. This is my suggestions already. And Oshin is, it's a very good presentations. And I think there is a very, very good attendant here.
Yeah.
And that is the initially what I meant, that is this is definitely our subsection hereby very exciting and interesting what I have at the very beginning, and the encouraging to all of us. It is a good academic sessions. That is what I know.
And so
I
in that
should
context,
request yeah.
So I in that context, you are rightly said that, I was, made aware that many of the subsection meetings actually are having less attendance, about 10, 15 or 20, but always we have kept a headache subsection, so more than 50 attendants. But I think we should increase more, because now our subsection members have increased to more than 220. And Ashish, you have this onerous job on you to include and ask for more participation from all the members. They should come forward, give participation, and we should have more attendance. At least I would be looking at least 100, 150 attendance for our subsection meeting. So you have created the WhatsApp group. So kindly through that WhatsApp group also you periodically inform the members about the upcoming subsection meetings, and whosoever wants to participate, with the case, they are most welcome. And I think then only we can take it to greater heights, all these variations. So that's very important.
Definitely.
Right. So I thank you, everybody. And Ashish, can we call it a day? Can you give your concluding remarks?
Yes, sir.
Yes, sir. So as sir said, I would just like to request all members, those who sometimes we have wrong email IDs and sometimes we have wrong mobile number. So those of you who are members of headache subsection, kindly forward your email ID or correct email ID or correct phone number to our headache subsection email ID, which is headache.in@gmail.com, so that we can include everybody in that mailing list in the WhatsApp group. And as sir said, please, everybody is free to participate in this subsection webinars, present cases or whatever interesting papers or something other presentation they want to do. So please do send your proposal to the email ID, and we will
And
make
I
sure
have
that
some, I have some, interesting, suggestions later on to be more inclusive. So we'll discuss that later. Okay, so with your permission, we leave the meeting and thank you very much. Have a nice weekend. Thank you.
Okay, thank you.
Thank you, sir.
Thank
Thank you, everyone.